Hello, my name is Angela Norris, and this is my evidence-based project presentation on pediatric pain management. As a pediatric nurse, I commonly see postoperative patients with PCA and postoperative patients with as-needed medications, which made me question which method is more efficient and led me to create my PCOT question. In pediatric patients, does patient-controlled analgesia, when compared to as-needed nurse-delivered pain medication, result in greater pain control and faster recovery in the post-surgical period? The databases I conducted my searches on were Medline, Gale, CINAHL, and ProQuest. I used terms such as pediatric, postoperative, analgesia, pain management, and study, and I limited the search to only include articles published between 2010 and 2016, full text, peer-reviewed, and English language articles to narrow down the number of articles found. From these sources, I reviewed the articles and chose 3 articles that related best to my PCOT question. The articles I chose contained comparisons of pain levels based on PCA use and as-needed use, which would provide me with the most complete answer to my question. Article 1, Pain Management Following Major Intracranial Surgery in Pediatric Patients, a prospective cohort study in 3 academic children's hospitals. The purpose of this prospective clinical observational cohort study was to assess the incidence of pain, prescribed analgesics, methods of analgesic delivery, and patient/parent satisfaction in pediatric patients undergoing cranial surgery at 3 major university children's hospitals. Pain scores were recorded using age-appropriate scales such as Flack, Wong-Baker, FACES, and numerical. The study investigator did a chart review and patient interview daily on the patient's pain scale, the frequency, type, and mode of administration of analgesia, as well as conducting a patient and parent satisfaction survey. The type of patient-controlled anesthesia and nurse-administered IV analgesia consisted of morphine, fentanyl, or Dilaudid. The primary oral opioid was oxycodone. IRB approval and parental consent and patient assent was obtained. 538 pediatric patients undergoing cranial surgery were eligible. Of these, 200 met the necessary criteria and were included in the study population. Patients were included in the study if their surgery was performed by a specific surgeon, if both of their parents spoke English, if their surgery was scheduled for the daytime, and if a study investigator was available at the time of their surgery. Patients were excluded if they had to remain intubated after surgery, if they had an allergy to opioids, or if they had a known history of substance abuse. Data was entered into Microsoft Excel and exported into Stata 12 statistical software for analysis. Patients at Johns Hopkins Hospital were primarily treated with PCA. Patients at Children's Hospital of Philadelphia were primarily treated with nurse-administered as-needed IV opioids, and patients at Boston Children's Hospital were primarily treated with nurse-administered as-needed IV opioids also. The strength of this study was the ability to study multiple routes of analgesia and their effects in order to improve analgesia administration. Limitations included not having study personnel to recruit patients undergoing surgery in the early morning, at night, or on weekends. The second article I chose was a retrospective study of multimodal analgesic treatment after laparoscopic appendectomy in children. The purpose of the study was to evaluate the effect of their bundle of pain management interventions on the self-reported postoperative pain scores and complications. This retrospective study compared analgesic use in 2 groups: those with peritonitis at the time of surgery and those without peritonitis at the time of surgery. IRB approval was obtained prior to the study. The population included 206 children who had a laparoscopic appendectomy between December 2011 and February 2012. Children younger than 7, children with chronic appendicitis or incidental appendectomy, or those that were receiving PCA by proxy were excluded. Data was extracted from the medical record and included pain scores in PACU and during their inpatient hospital stay, dose and time of PACU rescue analgesia, PCA use during hospital stay, including the number of demand doses, the number of demands made, the number delivered, and the number of demands not met, the amount of time inpatient, and the reason for inpatient stay longer than 48 hours. The data was analyzed using Shapiro-Wilks test, students' t-test for normally distributed data, and non-parametric tests for data not normally distributed. The data was compared to Fisher's exact test. 201 patients had a morphine PCA, 2 patients had the dilaudid PCA, and 3 patients had as-needed IV morphine. Patients in the group with peritonitis had longer hospital stays, more pain, and more unmet PCA demands. The study points to the fact that pain can be reduced from prior rates when a multimodal analgesic approach is used. Strengths of this study was that it points out the benefits of multimodal analgesic use in post-op patients. Limitations included missing pain score values, which were unknown whether the child was sleeping at the time or if the pain score was just not done by the nurse. Pain scores did not differentiate between pain at rest and the pain at activity. Pain scores were recorded at set times, so they may not have been, the patient may have had pain medication prior to that recorded set time. And no pain scores were recorded after the patient was discharged to see how their postoperative pain was after discharge. Article 3, the safety and efficacy of continuous morphine infusions following pediatric cranial surgery in a surgical ward setting. The purpose of the study was to compare the safety and efficacy of continuous morphine infusion to standard oral analgesics in a neurosurgical ward setting. The method was a retrospective review of medical records. Group 1 had continuous morphine infusions with as-needed analgesia. Group 2 only had as-needed analgesia. Pain scales were recorded using age-appropriate scales such as the Flack scale, Wong-Baker-Faces scale, and numerical scale. Approval was granted from the Clinical Research Ethics Board at the University of British Columbia prior to the study. 71 patients who underwent cranial surgeries were included. 37 were included in the continuous morphine infusion group, and 34 were in the as-needed Tylenol and codeine group. Patients that had prolonged ICU stays were excluded, since this was a study meant for the surgical ward. Data collection. Data on pain scores and medication administration during 3 postoperative days was collected and analyzed using students' t-test for pain scale data and SPSS for statistical data. The findings show that there was a slight trend to better pain scores in the continuous morphine infusion group, but it was not significant. So this study has shown that both groups received adequate pain control. Limitations included the small population size, and it was limited to 1 hospital that data was pulled from. It appears that the benefits of PCA is that the patient has a continuous level of analgesia in their system, which allows for greater pain control, which may not be achieved with as-needed medications. I found that there is a lack of studies on this subject, and that most studies focus on the failure of nurses to do adequate pain assessments. In the few studies that I critiqued, the patients were given appropriate PCA or as-needed medications, which allowed for consistent pain control, which is not always the case, especially if the patient is not requesting as-needed medications and proper pain assessments are not being done. I will apply this to my clinical practice by doing more frequent pain assessments on my patients, especially on patients with as-needed pain medications. I will reassure patients that may think asking for pain medicine includes a painful procedure, I will reassure them that pain medication can be given oral or IV and should not cause more pain, but should help the pain. I will advocate for my patient if their prescribed pain control regimen is not controlling their pain, and I will offer more non-pharmacological pain relieving options, such as ice packs, warm compresses, calming music, and distraction techniques. Thank you for listening to my presentation, and I hope you have a great day.